Good morning, everyone. This is the San Diego Spine Foundation Monday morning lecture series, and super happy to have Gautham Prabhakar with us today. And Gautham is one of our fellows this year, came from San Antonio, and has done a great job with us this year so far, and is going to be sharing with us on the classification of metastatic spine disease. Gautham, thanks for being here, and do you want to share some of your take-home points with us?
Yes, sir. Well, thanks for having me. Yeah, I think it's an important topic, especially for any spine surgeon, whether you're at an academic center or a private practice for that matter. When we're faced with these patients, we at least need to have a basic algorithm of how we approach them and, how we either treat them or send them for appropriate care, because usually this involves multidisciplinary care. Throughout this talk, we'll go through just basic epidemiology, how to diagnose this disease process, and go over some important classifications and treatments that may help the spine surgeon, whether, again, at a big tertiary center or a small rural area, and give them a basic algorithm of how to go about managing these sometimes complex patients.
Love it. I'm really looking forward to your talk, Gautham. Thanks for being here.
All right, thank you. Yeah, as Dr. Mundis stated, it's a pretty, not the most riveting topic for us, but I think it is an important topic nonetheless. We were talking that any spine surgeon, whether in a private practice or whether at a big tertiary center, needs to know how to navigate these sometimes complex patients and also know when to get help from different disciplines. So we'll kind of go through this and hopefully we get through without too much pain here. So a little bit of epidemiology first. Metastatic spine disease, it's important to recognize because it's actually, the spine is actually the third most common site for cancer cells to metastasize to, following the lung and the liver. And obviously with this comes important implications and significant morbidity. Some brief epidemiology, there's 1.2 million new cancer diagnoses a year, and 10 to 30% of these folks will have spinal mets at presentation. And actually, as high as 20% of cancer patients, their initial manifestation of malignancy can actually be spinal mets. So mets are typically the most common lesion that we're going to encounter in the spine, relative to primary tumors, as those are much more rare. And they can originate from a number of locations. And if you think back to your tumor rotation and step one and all that stuff, you can remember BLT with a kosher pickle, and you'll remember these locations. And while these numbers do fluctuate, particularly with advances in cancer treatment, these are still going to be your five most common sites. So symptomatic lesions, they're typically found in the T-spine, followed by the lumbar, and finally the cervical spine. And getting to the pathogenesis here, there's various proposed mechanisms of how METS occurs, but one of the proposed mechanisms is the Batson's venous plexus, which is basically a valveless venous plexus that provides a route for metastasis from organs to axial structures, such as the spine, the pelvis, skull, and proximal limb girdles. And there are also two other hypotheses for METs, including the seed and soil theory, which states that tumor cells grow in compatible end organ environments, just as a seed needs suitable soil to germinate. And also the circulation theory, which is when tumor spread is primarily influenced by blood flow from the primary site. And if we go back to our basic sciences, we'll remember E-cadherin as a mechanism of intravasation and the sequence of immune surveillance avoidance and decreased apoptosis and other factors that contribute to this disease course. So now coming to diagnosis and clinical presentation, 85 to 90% of these patients with spinal METs will present with axial pain that is progressive, non-mechanical, and often with night pain. However, if the lesion gets big enough or undergoes any kind of collapse, they can present with mechanical like symptoms. So that can lead to radiculopathy, myelopathy, and true mechanical back pain as a result. So initially, like anything, you want a basic plain radiograph, AP and lateral of the involved area, and you can typically find either purely lytic or mixed lytic and blastic lesions. Lung, thyroid, and renal are primarily lytic, and 60% of breast cancer is blastic, as well as 90% of prostate cancer is blastic. So those should be higher on your list should you see a blastic lesion. And importantly, up to 40% of these lesions will not actually be visible on plain radiographs. One important sign that you can sometimes see is the winking owl sign. And you see that on the right hand here. It's effectively a loss of the pedicle due to bony invasion and destruction. And importantly, to visualize or fully appreciate a lytic lesion, there has to be at least 50% trabecular bone loss for it to be visible on a plain lateral radiograph. Nowadays, we rely mostly on advanced imaging to look for metastasis of the spine. If cancer or metastasis is suspected, then typically an MRI of the entire spine is done to evaluate for distant mets, and they can also be helpful for surgical planning. Of course, it's also useful to show neurologic compromise of the spine, and some findings that you may see are soft tissue mass, increased signal on T2 images, cord compression, cortical permeation, and importantly, it's 98% sensitive and specific. So it can show us a lot with good sensitivity and specificity. CT scan is also usually done to define the extent of bony destruction and maybe perhaps help with some instability findings. The sensitivity is a bit lower at 66%, and the specificity is 99%. And historically, Tactinium-99 used to be used a lot more, but with the improvements of current imaging modalities, I don't think they're as heavily relied upon. But something to be aware of is that myeloma or renal cell carcinoma as a primary can often have a cold scan, so that is something to be aware of. In patients where a primary carcinoma is not identified, obtaining a biopsy is necessary to rule out a primary bony lesion. And this is usually accomplished by CT-guided biopsy. And it's important to note that the use of a larger bore needle confers higher degree of accuracy. And the accuracy of these biopsies are actually quite high, especially and it allows for confirmed tissue diagnosis. So this is tremendously helpful. We got to remember that we shouldn't treat a bony lesion without a tissue diagnosis of the lesion. So this is definitely imperative. Also, if your differential includes lymphoma, you do want to get some histologic and microbiology analysis of the lesion, and you should also send it for flow cytometry. We got to remember the age-old wisdom of, culture all path and path all cultures, as it holds true here, since infections can kind of mimic what otherwise would look like a metastatic lesion. Here's an algorithm proposed for the workup of these patients who present with pain in the context of spinal mets. Obviously, you got to examine the patient, get radiographs. If they're normal, usually you're just going to go into the non-surgical treatment side of this algorithm. But if there are some red flag symptoms or new symptoms, you kind of go to the right side of this, and you'll need the MRI, labs, and kind of a focused metastatic evaluation, which can include bone scan, CT, abdomen, pelvis, chest, looking for sites of primary, and even potentially biopsy to confirm a and get a tissue diagnosis so that you can plan for surgical intervention or treatment. All right, so now for classifications, this is the first, the famous Anakin classification that we use a fair amount in general orthopedics and tumor in orthopedics. This is for musculoskeletal sarcomas and also used for metastatic lesions in the spine, and it gives us a sense of both the biological aggressiveness and whether or not there is metastasis. And it's a relatively simple classification system, which makes it easy to use. But one particular downfall, in terms of the spine at least, is that it doesn't account for the epidural space, and thus it's not the greatest for describing tumors about the spine. A more focused classification proposed by Weinstein, Boreani, Biagini defines the spine in 12 radiating zones and also 5 tissue layers, moving superficial to deep. And then each one of these layers gets cut into these 12 pieces that you see here. And based on the number of layers involved and the number of radians involved, surgical planning is then kind of dictated. The original paper had 24 patients, and they used this system to classify the patients retrospectively, and they showed that patients had a higher rate of recurrence if they had multiple sites of involvement, and also a higher rate of recurrence if they had multiple tissue layers of involvement that otherwise wouldn't have been captured by these older scoring systems. So, the more specific you can be about the tumor location and what exactly it's doing, I think you can more accurately predict your treatment. The Tomita classification system, it looks at things on a more, I guess, holistic level, rather than breaking down the vertebral body into radiants. And it looks at regions of the spine and breaks it down into increasing order of aggressiveness or spread, with type 1, 2, and 3 lesions being intracompartmental, followed by extracompartmental in multiple sites. In this study, they had 18 patients with type 3 or greater lesions, and these were treated with en bloc spondylectomy. And this paper kind of goes into the technique of that, and you can see these pretty interesting diagrams and explanations of extrapleural dissection and the use of these Tomita saws on the right, from which the classification system is named. The ESCC scale, this classifies METs in terms of spinal cord compression, and this system was born out of the concept that, spinal cord compression is talked about and agreed upon, but there was no defined, terms of the extent of how much or the extent of spinal cord compression. So this was made to have a way to reference how much spinal cord compression in a systematic classification system with some objectivity. They defined the degree of compression based on whether it's only in the bone, how much epidural impingement there is, and if there's true spinal cord compression or total obliteration of CSF. Another classification system, this is based on neurological symptoms more than anatomic location, and it's known as the Harrington classification. It's useful in terms of the surgical indications. However, the big downfall of this classification system is that it doesn't have very concrete or objective definitions. In addition, it doesn't have great integrator reliability as to which category people fall in, and it has a very little granularity in terms of the neurological symptoms. So patients with frank paraplegia or just radicular type symptoms kind of can be put into a misclassification, if you will. So it doesn't do the greatest job in predicting life expectancy or functional outcome. Another classification system that we may be more familiar with was to basically look at the stability, and it's the Spine Instability Neoplastic Score, or SINS. This was put together by the Spinal Oncology Study Group as an expert consensus, and they looked at a number of factors, including the location of the tumor, pain with change in position, how much collapse there was, as well as radiographic parameters and the nature of the tumor. They get a score out of 18. 0 to 6, they counted as stable. 7 to 12 was indeterminate and possibly unstable. And 13 to 18 was true instability, and anyone that got indeterminate or unstable were warranted at least surgical consultation. Again, this had some factors that are difficult to assess on imaging and ultimately had poor intra-observer and inter-observer agreement, even after this consensus was generated. Tomita, in addition to his classification for the anatomic location that we looked at, he also developed a scoring system. This scoring system, in addition to being prognostic, attempted to assist in surgical planning and what you should do. They looked at 67 patients retrospectively that they treated according to this algorithm. You can see here on the right. The scores, as they increase, have a more aggressive nature, and then the treatments kind of follow as such with their algorithm. They had good success in terms of their goals and treatment for each level of involvement in each score, but obviously, as your score goes up, your mean survival time goes down in an inverse relationship. So by now, I think you've seen kind of a pattern that many of these classification or scoring systems have a number of parameters in common. You know, they look at general condition, overall health, extent of bony mets, and some of them will look at visceral mets. And then varying degrees of focus on the primary sites, the amount of neurological involvement. And based on these factors, they'll try to predict survival and see if it's warranted to undergo the risk of surgery. And some of them also assist in surgical planning, you know, based on whatever score they you get. So this was another study, a 1990 study, excuse me, by Takahashi, which was primarily focused on prognosis. They had 64 patients, and they recommended excision for greater than 9, palliation for 5 or less, and then this was then updated in 2005, with the main change being that the primary sites of tumor were greater stratified to go from 1 to 3 to all the way up to 5, with the more aggressive tumors getting a score of 5. And so this kind of shifted the overall score, also gave us a bit more granularity and a better predictive value based on the primary tumor that was involved. So the important things to note here is that a prognostic score, it was based on 6 elements: general condition, extraspinal bony mets, number of vertebral bodies with mets, visceral mets, primary tumor, and neurologic compromise. And taking these 6 elements, you can get a score. If it was 0 to 8, they suggested that the mean survival period was less than 6 months. 9 to 12 would be greater than 6 months, and a score of 12 to 15 would be greater than a year. So the other system that is still widely used and agreed upon is the SWORD Classic. This was an algorithm, basically it was an approach scoring system that looked at about 650 patients with multivariate analysis to look at factors that would influence survival. And you can see here on the right, similar kind of parameters that were looked at: age, mets, whether visceral, systemic therapy, and they also had some lab values such as WBC or hemoglobin. And from this, they were able to generate a nomogram that you could kind of go through, and it would help you calculate 30, 90, and 1 year survival probability. So certainly a useful tool. Katagiri, a little less widely popularized, but you can see from the table on the right that they're starting to get a little more granular in terms of the primary tumor and the kind of the growth of it. So they subcategorize these into slow, moderate, and rapid carcinomas and cancers. But it also shows kind of how responsive they are to treatment. So this was a comparative study of 9 different scoring systems, some of which we've talked about here. And they used receiver operator curves to model the accuracy of each of these tests. And they came to the conclusion that the SORG nomogram had the highest accuracy at 30 and 90 days, whereas the original 1990 Takahashi paper had the most accurate at predicting 1 year survival. And so it's a good paper to have as a reference because they go into the accuracy of all these different scoring systems. But they also give you a suggestion based upon what kind of cancer the patient has, which scoring system would be most beneficial to you to help assist the patient. This was a literature review looking at all the classification systems at the time. There was 6 classification systems, 23 scoring systems, which you can see. And basically they were looking at with the most common. If you look on the right, most of the articles went into primary site um, where the primary tumor was, and also whether or not they had visceral mets. Most of them had some perspective on the general condition of the patient, some lab values, and whether or not there was any bony mets. Some important factors, however, not accounted for in these were the fact that treatment now is occurring immediately following the detection of METs, and that the detection of METs in an asymptomatic period is becoming more and more common as MRI scans and advanced imaging are becoming more frequently utilized. So obviously this is going to change the outlook for some of these tumors. And so that's what this paper kind of went into, acknowledging those factors. In addition, they do describe and talk about the rank ligand and bisphosphonate treatment options that may be decreasing this burden. So briefly on some treatment, looking from a historical perspective, this is a paper all the way from 1978, and they had 235 patients treated with laminectomy, followed by radiation therapy versus radiation therapy alone. The primary outcome was ambulation, and they found that there was no difference between the two. So this made a stance against surgical intervention, actually, for spinal cord compression at that time. Then 9 years later, there was a retrospective study looking at excision primarily through vertebral body resection versus laminectomy, more speaking to the decompression as a function of taking pressure off the cord from the area of compression, which typically is going to be anterior base compression and spinal mets, rather than just looking at whether or not surgery was done in their study. So they had about 60 vertebral body resections and 25 laminectomies. And in almost every parameter, the vertebral body resections did better. And surprisingly, the mortality and morbidity after surgery was pretty similar. And the only main difference was that the laminectomies actually had worse wound healing. So this was the kind of groundbreaking paper. It was in Lancet, randomized multi-institutional non-blinded study looking at spinal cord compression caused by METs. 50 patients had surgery after radiotherapy, and 50 patients had radiotherapy alone with ambulation as their primary endpoint. Secondarily, they looked at urinary function, strength, functional status, and whether or not they needed steroids or pain medication, and of course, overall survival time. The reason they only had 50 patients in each arm, despite I believe their power analysis of having 70 in each arm, was the study was stopped early due to early stop criterion that was preemptively set. They had significantly more patients in the surgery group that were able to walk after treatment. They retained the ability to walk longer. And 32 of the patients that entered the study unable to walk, if you look at these, significantly more of them regained the ability to walk with surgical intervention as compared to radiotherapy alone. So this was the study that showed that direct decompressive surgery plus postoperative radiotherapy was superior to radiotherapy alone. And here's a more modern update on where we're at with some of these factors that affect spinal med surgery today. Specifically looking at timing between radiotherapy and surgery. This is a systematic review from 2020 looking at this exact question and also attempting to establish a safe interval. They reviewed 41 articles and ultimately came to the conclusion that there was insufficient evidence. After their review of the literature and discussion from experts in the field, they came to the recommended interval of 2 weeks with a minimum of a 1 week period between radiotherapy and surgery. They note that focused stereotactic surgery can further reduce post-op complications. They also noted that if your window is too long or greater than 12 months, that wound complications tend to rise, and postoperative radiotherapy has fewer wound complications than pre-op, but you do lose some of the effects of the tumor being shrunk if you do postoperative therapy, whereas in the preoperative period, you'll hopefully have a smaller burden of tissue to take out if it's radio responsive. Here's an expert opinion and systematic review of some important factors during spine tumor surgery, including choice of bone graft and construct design. About 40% said that they used bone graft to accomplish their surgery, and the most common was a structural allograft for anterior reconstruction. Surgeons were also using cages and cement as well. Interestingly, the concept of bony union was rather debated in terms of whether or not it's an important thing to strive for with these uh, in your constructs in treating these patients. They did recommend an anterior construct with bilateral posterior instrumentation when performing a three-column resection. They surveyed all the surgeons in terms of what was important to them, and you can see here from the graph on the right that life expectancy was almost across the board one of the most important things, as well as how easy it was to approach in terms of anatomic location, bone quality, and patient age. Finally, this was a review paper looking at techniques and indications of MIS surgery. Of course, we're in San Diego, so we got to talk about MIS surgery. It doesn't have a tremendous role here in tumor surgery, but nonetheless, it was an interesting paper to look at. They looked at separation surgery, which is basically trying to remove the metastatic burden from close to the neural elements to allow for radiosurgery of these tumors. There was 29 articles, and the indications were similar across all the articles in terms of why these surgeries were being done. And generally speaking, they showed that complication rates were similar compared to traditional approaches. However, some of the articles they looked at did show statistically significant improvements compared to traditional approach using MIS surgery. And the ones that tended to have the strongest evidence were the mini open techniques rather than some of the other MIS approaches. But generally speaking, their conclusion was that the quality evidence was quite low in terms of the papers that they were looking at, and of course, further study is necessary. Um, so that was pretty much the end of it. Hopefully, everyone's still awake. When you're approached with these patients, there are some easier avenues rather than referencing all these papers. They have some apps out that can help you. There's a Sorg app here, and you got 4 out of 5 stars, so it must be pretty good. So, go ahead and
2 users.
yeah, that's right.
Yeah.
Yeah, download it. It'll help you. Thank you,
Thanks,
guys.
Scott.
So Gotham.
Yeah.
Patient comes in with metastatic lesion, you consult it.
Mhm.
Like say it's thoracic spine, like what are you using to make your decisions? What are you gonna do?
Yeah, I mean, I think going through the basic workup, examine the patient, assess for any neurologic compromise, starting from plain radiographs all the way to getting to MRI and CT, and seeing if I can identify any primary site. Obviously, if there's a primary site, I'll need to get multiple disciplines involved. But if it indeed is a primary,
You're consulted, so you don't have
if
to
I'm
worry.
consulted,
Yeah, you're hardly ever gonna be like, even if you find someone in a clinic, when you admit them, they're gonna probably be admitted to medicine. Like you're not gonna, so but your role is to now figure out,
Is it
how to
met-
direct the care
yeah,
of the spine. What are you using to help direct the care?
I think imaging and a combination of these classifications. I think the Sorg would probably be the best one, but I think imaging to tell me, is this something that needs directed tumor care, surgical decompression, or is this something that would be radio responsive that can just be managed through that without surgery?
And the facilities you guys go to will have different sort of takes on it. Like San Diego is a very heavy radiation based environment. Like we hardly ever see patients.
Mm-hmm.
It's because they're all getting radiated. For better or worse, I would say. Like, I mean, I think we overdo it here. I don't think we use our skill set enough in the spine world.
And Greg raises a good point. I think, like all of this historical perspective is really important. And it's cool because a lot of people that did the majority of like the contemporary work in this are still around and like will answer your emails. Like Bilski in particular, Cornell is just the man and super like dedicated to this. But like beyond the frameworks, I think the important thing is that you think of spinal metastases, like you outlined, Gautham, as basically stability, oncology, and neurologic issues. And our role as surgeons, for the most part, in the context of metastases, is to facilitate radiation therapy. I mean, that's the definitive treatment. Like, that comment about, if they do radiation first, then there'll be less tumor to deal with. We're not really there to deal with the tumor. We're there to basically set up the radiation oncologist. And so Greg's point about San Diego being like a little bit radiation heavy, I mean, that's fine. And that's how the majority of lesions should be treated. The one caveat is that because of the potential cord toxicity from the isodose line from the radiation plan, prevents them from delivering an appropriate tumoricidal dose, and then they get incomplete treatment, and then they come back with cord compression, well, then you're kind of in a difficult spot, because then you can't rely on the real treatment, which is stereotactic radiosurgery, and they're likely to continue to have recurrences. So I would just, obviously the neurologic issues and the stability issues, I think, are pretty straightforward, and you can use the same surgical thought process as you would for other spinal disciplines.
Right.
And there's scoring systems that'll really help you. But what I want your mindset to be is okay, obviously I got to take care of neurologic issues. I got to take care of stability issues. I'm a spine surgeon. I can do that. But then you have to kind of switch hats and get disciplines involved and really understand, okay, I did a case on Friday, and actually call the radiation oncologist and be like, hey, how much space do you need? Because that's how much bone, how much ventral bone I'm going to take, how much of a corpectomy I'm going to do is going to be predicated on how much space you need. And you're really just you're kind of like the assist in a lot of ways for the radiation oncologist. And I think that's the mindset that's going to move the ball forward.
Got it.
If you train with Dan Schuba, he'll cut everything out. The Dan and Bilski are sort of on opposite ends of the spectrum, wouldn't you say, Annie? And
I would.
Dan is
yeah, and I think he's awesome. I don't know, maybe
really
it's because
aggressive on the surgical side of things, or on the curative, this will never be a problem again, and he takes everything out. And probably, I mean, you can think of both ways of doing it. I personally am a little bit more in what Hanny's saying. I like that better, because I think the radiation oncology is that is dialed in. It's really incredible what they're able to do, and that technology is evolving. And
100%.
it makes sense to me, because you're trying to do the least traumatic thing for that patient, because their life expectancy is already short, right?
It's palliative.
So,
and if they've got spine mets, they've got disease elsewhere. You're not going to cure their cancer with a spine operation. You want to maximize their quality of life and also facilitate what you can for your radiation colleagues. And again, no disrespect to Dan. And if it's there and it's low morbidity to take, like epidural stuff, grab it, get it out of there. But if you're thinking about doing a full corpectomy or something like that just to get tumor out, that's not going to be, unless there's some kind of stability consequence, that's just not, in my opinion, the right way to go. So you really have to be palliative in your mindset and realize that you are not like the quarterback. You are left tackle. I don't know. You get the analogy.
Right. So, for instance, if you do it, even from a stability standpoint, if you do corpectomy with the cage and anterior support, you might just have to go 2 up or 2 down, right? Versus if you're stabilizing it with a LAMI, you may have to go 3 up, 3 down. Morbidity of adding 4 screws versus sitting there dissecting around the spinal cord, taking out the vertebral body, putting in the cage, and all the passes around the spinal cord, all the chances for horribleness. That surgery is very different, right? It's one's an hour and a half, and the other 2.5, 3 hours, right? So it's you're doubling operative time, you're doubling complications, and so you have to weigh that in the mix. And if they don't need it, radiation oncologist, then why are you doing it?
Right.
Yeah, I like it.
Thank you.